So thanks, Pramod, for that warm introduction. Thanks, everybody. So what I thought we will do is go through some of the use cases that we have been working at IIT Hyderabad so that you can develop a better association, can think of some problems potentially that we can solve as we go ahead. So with that, let's go ahead. So I think a lot of context, thanks to the wonderful talk by my predecessor, Dr. Sabine. I think she covered all the possible areas where AI has a role to play in public health, more public health than AI. But the story, if I were to look at, if I were to get the big picture, monitoring and surveillance, the population screening, a lot of use cases that we do are in the population screening helpline, some in population mental health, risk stratification. Health communication is one of the most obvious ones, which is as much of digitization as much as it is AI. And MNCH, the community health worker stuff that we have talked about, all of this stuff. But the key thing also is that 70% of the public health related AI evidence, whatever statistics that we are talking about, what is working, what is not working, is coming predominantly from the developed world. And this point was also highlighted in the last session. So there is a lot of scope and a lot of need for us to do and embrace more AI. So what's stopping us? So these are challenges, whether it is in public health or not. There are a lot of challenges in adoption of AI, but public health even more so. One of the things is that we see so many solutions that are presented in a lot of hackathons, in the accelerator programs, which appear promising, but there is a huge chasm from pilot to scale for a variety of reasons, right? Lack of interoperability. Again, the data is there, but then can you use the data from across? There are a lot of issues, right from syntactic interoperability to semantic interoperability. Bias, I guess that's even more important in the public health because India is a vast country and most of the models are originating from the West. Can you apply them in India? You got to do due validation. That's very important in India from a public health standpoint. Workforce gap, I'll go on, lack of open data sets. We keep hearing that in the research community again and again and again. India, the data should be the strength of India, but we need to do more. All of us, we need to do more to make these data sets available for research. Fragmented data, lack of integration, AI, again, I'll just stress on this. AI is always thought of as a model, but AI is a whole system, including the patient who is a part of it. He or she needs to be convinced that whatever we are doing is of use to them, and it should fit well within the workflow of either a frontline worker or the primary care physician, so that they are not spending extra time and it is very well integrated. Absence of local validation, that's happening, donor dependence, and lack of trust and regulatory clarity. I think this is one of the challenges that was thrown at us. There are so many promising things. Why are they not getting adopted? The blame sometimes is not the blame, but the state which is supposed to adopt them, they lack the required trust and confidence that these would work in their environment effectively for them to go ahead with them. So that's one of the problems that we are trying to solve as well. But it's not all dark. There are many good, successful public AI-driven public health successes in India, especially on the tuberculosis. It's been adopted at a population scale. AI is doing, in some cases, the preliminary identification from the chest X-ray is doing a phenomenal job. And it reduces the dependency on radiologists significantly. Not just one, there are several initiatives on TB which have been attempted at various parts of India, proved successful. Diabetic retinopathy, I mean, this is one which I have heard even yesterday. Google was, in fact, among the very first AI interventions to detect diabetic retinopathy has originated in India, where Google worked in collaboration with Arvindaya Hospital. It took a bit of time for it to roll out, but then we do have some public health related initiatives around this identification, and there are more on the maternal and community health. So there is a lot of things to drive motivation from, and that's what we take as an inspiration when we go ahead and work on these various cases. Now from there on, so let's talk about some of the real use cases with that as a background, right? So I'll go through about 6 of them, not all of them. Some of them our center is directly involved in, but then some of them there is a whole lot of work happening in IIIT Hyderabad. It takes me a lot of time to figure out what useful thing that I can leverage is happening. So it's constantly a discovery process. So this is something, and all use cases, one thing which I'd stress, all of use cases are being worked with a definite partner. So we not only are building a solution, but we are building a solution which can be taken and deployed to the ground or already deployed. So the first use case is with Grace Cancer Foundation, cancer risk stratification. So Grace Cancer Foundation is being run by Dr. Chinnababu as well. This is deployed, integrated with the EMR. So they do large-scale screening programs in rural areas. And for all the relevant ones, they do undertake X-ray, mammograms, and pap smear. So they do have all of these reports. They have established a workflow. So all of these are viewed by a radiologist, and then the reports are generated. The bottleneck, sometimes because of the low resources, right? The bottlenecks emerge in new places which are not very obvious in a clinical setting. So the bottleneck in this particular case is that how are we going to process these reports and identify and reach the people who are at the most need upfront? Because the whole purpose of this screening is so that you can identify the people and get help to them on a fast basis. So what we are doing in this is that there are a wide variety of reports, not just these 3 modalities, of course, but they come from various formats, various radiologists. So there is not a consistent way in which they are presented. So we kind of make sense of them, digest them, standard AI techniques, then you kind of move them into a structured form. And then the most explainable way is identifying appropriate phrases and keywords which say, hey, who is at a higher risk? But we need to attribute the negativity appropriately, identify the keyword appropriately, even if there is a synonym. So standard NLP is what we have used because we found that that is the one which can hit the ground the fastest because it is readily explainable. You can look at it, radiologist would understand, and then he can really act upon it. But at the same time, given the promise of various other things that are happening, we have been applying the open models, the MedGemma models, as well as the frontier models in a variety of ways to see if they can stratify the risk directly from the image, or we converted the DICOM to PNG, or can we use them to generate the report and use NLP techniques that are working well for us, right? So at present, we are not confident that the secondary things that we are trying are good enough to be deployed in a real setting, but we feel that there is hope there. So moving on, endometriosis screening. Endometriosis, as I gathered, we are working with Endometriosis Foundation of India, led by Dr. Vimi Bindra, a gynecologist who is working with Apollo Hospitals. So this particular disorder, we understand, affects 1 in 10 women in reproductive age and very poorly understood. So they have, this particular facility does have a lot of patients of this kind. And being a doctor and with a research interest at heart, the center has created an EMR which captures about 250 odd features for every patient. So we wanted to see, can we make use of this and identify due signal which can be then taken to the public health for self-service or self-assessment. So we took this 250 plus features, reduced, we looked at what is really valid feature to look at, what is not, because something if it is already indicative, a surgery is probably already indicative of endometriosis, we didn't want to use that again to predict endometriosis. So we kind of narrowed that down. Again, non-availability of data in some cases was an issue. We narrowed it down to 90 features, and then we made sure that there is a reasonable representation because this is a specialty center. We had a lot more cases of endometriosis than not endo. So we played with the distribution shifts, recalibrations and stuff like that. We got a reasonably good model which with an F1 score of 0.9 plus. And sharp values make sense, but then, so we use the whole idea is that we use this as a starting point and then create a questionnaire which is simple enough, can be used in a self-assessment on the field, and then derive the actual model to be taken to the ground on that basis. This was the first step, and we need to make sure that we are reaching the people and they have the right incentive for us to get the data and for us to deploy a model which can be really useful. The third, anemia detection. There have been various attempts. This is not unique. But then what is different, why we still undertook that is that there isn't an open model that is performing well in India that somebody can say that, hey, this works well and this is why it works well. So we have gotten some data and that performed reasonably well. A mean absolute error of 1.1 grams per deciliter. We are using a deep learning model which from the whole eye, which at the same time identifies the conjunctiva from the eye and then tries to identify, hey, what is the value of HB from that. We don't intend to use that for HB determination, but we thought that we would use it for identifying whether somebody is grossly anemic or not. So the other one is nutrition scanner. Again, a lot of use cases. We took it up because we thought it's a very relevant problem in the public health. There are at least 2 different initiatives running with us. One we are doing with AIG Hospitals nutritionist team with their public health initiative, and another we are also working with nutrition with NIN for a similar need. So one of the learnings from this is that we developed a model, and obviously there were 2 parts to it: identifying a dish and then estimating the volume. For identifying of the dish, we could readily develop a model which was very high performing, but generalizing was a big problem in this case. Then realizing the strength of the LLMs. What we are currently doing is we wanted to get a baseline first. We are using the frontier models, a variety of options, to get a baseline which appears good enough to solve the problem at the beginning, both for dish identification and for the weight estimation. So in fact, so much so that these models appear to be better than some of the commercial options that are available on Google Play and App Store. So this is one very interesting one, digital mental health. So we are working with Choice Foundation. This is not our center. Raj Reddy Center is another center. So what we are doing is that they do a lot of public health screening, and the idea is that how do you screen children for some specific psychological issues that they might be facing. So they collect handwriting samples as well as house, tree, and person. There's a specific psychological framework where you ask a child to draw a house, a tree, and a person, and a psychologist assesses. They spend about an hour trying to identify the subjective traits. So we have captured about 30,000 such drawings, and the idea is that from that we will get AI to generate the first feature identification and psychologists to only selectively review and approve that, saving time because that was the biggest bottleneck. And lastly, oral cancer detection. I think that will speak for itself, but I would go to the last slide in the interest of time because I thought that was also important. So what we are doing is that the problem in a lot of cases, there are a lot of models, but there is no confidence that they were developed the right way for them to be deployed on the ground. So we have reviewed a whole lot of literature on what are the reporting, publishing guidelines and the development guidelines, and we evolved this as a solution where we thought that we would run through 5 different components: problem, data, model, systems, and site deployment, have a multidisciplinary team of clinical researcher, clinical specialist, AI researcher, and a systems architect, look at the system as a whole, and through 5 focused discussions, assess all information to be able to provide our commentary on how ready is the model for deployment, actual deployment, or what should be the next steps that we should undertake. So that's in works. We hope to put that to use sometime and make a difference. Thank you all for the time.